Hello, this is Dr. Nicholas James. I'm a second-year medical resident at Coliseum Medical Centers. I'm here to discuss a very interesting case of disseminated cryptococcus in an immunocompetent patient due to prison yard pigeon exposure. We discussed the unique presentation of an immunocompetent former inmate who was admitted to the hospital due to symptoms of dyspnea and fever. After a thorough history physical exam and diagnostic testing, the patient was diagnosed with disseminated cryptococcus. The patient has since made a complete recovery and was discharged home after receiving careful medical management. The prison system is a breeding ground for the contraction and transmission of a variety of infectious diseases, and these diseases oftentimes remain with the prisoner even after they've completed their sentence. According to statistics by the United States Department of Justice, the prevalence of an infectious disease within the jail and prison population was 14 to 21%. We review the rare presentation of an immunocompetent former inmate who was exposed to pigeon droppings during daily recreation time in the prison yard, resulting in disseminated infection by Cryptococcus neoformans. This case reviews the medical management of a 55-year-old gentleman who presented to the ED with symptoms of nausea, vomiting, and headache, lasting 3 months in duration. His daily recurrent tension-like headaches progressively worsened over that time period. Physical exam was grossly benign. The patient was admitted to the hospital for additional workup and medical management. Upon admission, the hospital medicine team conducted a thorough history and physical exam, which revealed that the patient was recently an inmate and exposed to pigeons at the recreational area of the prison. When questioned, the patient admitted seeing pigeons lining the fences of the outdoor area where the prisoners exercised on a daily basis. Differential diagnoses were very broad, as the patient's symptoms were very nonspecific. Imaging studies included chest x-ray with bilateral lobar infiltrates. Bronchoalveolar lavage with visualization of encapsulated yeast forms were noticed. Head CT was negative for mass effect or hydrocephalus. LP showed a small amount of clear fluid, with opening pressure that was too low to measure. CSF analysis included a protein of 123, CSF glucose of 38, white blood cell count of 43, and CSF lymphocytes of 90%. Specialized CSF analysis revealed a positive cryptococcal antigen titer of 1 to 20. However, ND ink staining was not conducted at that time. Final blood culture was positive for Cryptococcus neoformans var. Grubii. The patient was deemed immunocompetent based upon his history. He denied chronic steroid use, history of immunodeficiency, or chronic lung infections. Furthermore, immunoglobulins and complement levels were drawn and found to be within normal limits. Finally, the patient had an HIV test performed that was negative. Over his 21 hospital stay, the patient's condition stabilized with treatment consisting of amphotericin B and flucytosine. Cryptococcus neoformans infects over 1 million vulnerable patients worldwide annually. Cryptococcus, the disease caused by the Cryptococcus species, results in over 600,000 annual deaths worldwide and is one of the most prevalent opportunistic infections amongst the population of individuals living with HIV. Due to its relatively high mortality rate, the WHO recommends that HIV patients receive cryptococcal antigen screening if their CD4 count drops below 100 microliters. The Infectious Disease Society of America does not routinely recommend prophylactically treating HIV-infected individuals in the U.S. or Europe against cryptococcosis due to its widespread use of antiretroviral therapy. In this case, our patient was started on fluconazole after the bronchoalveolar lavage revealed yeast, but was transitioned to ampho B and flucytosine after the titers returned positive for cryptococcus. Disseminated cryptococcal infection amongst the immunocompetent is very rarely documented in medical literature. Immunocompetent patients most often display the manifestation of cryptococcal infection with skin lesions or pulmonary infections. The criteria for disseminated cryptococcosis is the discovery of positive blood cultures or positive cultures from two bodily locations such as the skin, lungs, or CSF. In this case, the patient satisfied the criteria with a positive blood culture, bronchoalveolar lavage with encapsulated yeast, along with CSF analysis that featured a positive cryptococcal antigen titer of 1 to 20. In conclusion, the prison system has limited resources to control communicable diseases. This results in the spread of well-known diseases such as hepatitis or TB amongst inmates and the general public when former prisoners are released from custody. The prison system may also expose inmates to rare infectious pathogens that might ordinarily be overlooked. A broad differential diagnosis list and a thorough bedside history are important in these patients so clinicians won't overlook infections that could lengthen the time to correct diagnosis and treatment. Thank you very much.